Howdy, y'all. Today we're going to talk about um, competence and decisional capacity. This is part 3 of section 1 of ethical issues in modern medicine. And we're just going to talk about the one reading, the Buchanan and Brock reading, deciding for others, um, as the other readings have to do with sort of the cases. And so this is the one that actually kind of gets to some philosophy and gives you some sense of a position on this issue. So anyway, like I said, we're talking about the Buchanan and Brock piece, and what I'm going to do here is just kind of go through the paper because it's structured kind of weirdly, and I just want to make sure everybody is kind of clear on what's actually sort of going on in the piece that you've read, because it starts with these 5 questions, and then it says, well, we're only going to talk about some of those questions. And then even sort of trickier is that one of the questions that they say that they are going to talk about, they don't talk about. So it gets kind of wonky, but let's just sort of start with what they do talk about. So the point of the majority of this reading is to talk about the theoretical underpinnings for sort of figuring out what competency means, right? What does it mean to say that a patient is competent or has decisional capacity? Sometimes those are used interchangeably, but they do have sort of slightly different meanings. But anyway, the 2 questions that they put forth that they're actually kind of answering in this paper on page 332 is what is the appropriate concept of competence? And then given an analysis of the appropriate competence, what standard of competence must be met if an individual is to be judged competent? So the concept of competence is sort of the first question that they try to answer, and that's the first sort of large section of the paper. So to give that, and we'll get into that here in a little bit about sort of what's going on in that section. But the second sort of big section is this sort of underlying values of the standards of competence. So again, we'll get into more detail here in a minute, but very briefly put, the underlying values are well-being, which is a consequentialist utilitarian kind of way of thinking, and the other is self-determination or autonomy, which is more in line with sort of the Kantian way of thinking about things. But anyway, after that, they sort of move on to a further discussion of the standard and how to decide on the standard. And again, both of those are kind of related to what standard should we use for determining competence. So what do they not talk about? Well, they don't really talk about the third question, which is the most reliable operational measures for determining whether the standard is met. There's a little bit of a discussion about the relativizing the need for determining competence based on the risk of the refusal of getting treatment, but for the most part, their focus is on the standard stuff. So operational measures and the fourth question of who should make the determination or who has the authority to determine competence, and the fifth question of what sorts of institutional arrangements are needed. All of those are sort of more of the practical concerns of sort of how to sort of implement this standard if it were to be adopted, and and are sort of left out of this reading. So there's more that Buchanan and Brock have written, but in this case, we just have this sort of first bit. Okay, there is one section though, which is kind of the wrapping up kind of the point of the entire essay, which is to contrast the author's view about sort of the appropriate way to think about competency, which is what we're going to call the decision relative capacities view, or just the decision relative view, versus the fixed minimal capacities view. So their conception that they're defending is more decision relative, as opposed to sort of the traditional view of thinking about capacity, which is having sort of a minimum set of decisional capacities. So it's not relativized to the decision being made or the situation that the person is in, or so on and so forth. But anyway, that's the paper sort of in a nutshell, and we'll sort of briefly go through each of these sort of major sections just to kind of point out what's going on, just to make sure nobody is confused, and maybe we'll answer some questions. Okay, so let's start with the concept that they're defending. So it is this sort of decision relative view, and their view is that competence is decision relative. It's relative to all these sort of different kinds of factors, and I'll just sort of quote them here. A person may be competent to make a particular decision at a particular time under certain circumstances, but incompetent to make another decision or even the same decision under different conditions. So their view here is that decisional capacity is in fact sort of relative. And again, this is going to be contrasted at the end with this fixed minimum threshold view that they think is sort of the wrong way to think about it. So as we go forward, we're gonna think about how sort of their conception is going to work, and sort of what sort of goes into sort of thinking about this. And then at the end, you'll get sort of an argument about sort of why this conception is better than the standard view. All right, so a few notes that they make in terms of capacities needed for competence, and this would be true for any sort of view of competence, but just to kind of fill this in, they kind of divide things into sort of three groups. One of the things that you need is communication and understanding. The other thing that we would sort of look for is the capacity to sort of reason and deliberate. So being able to understand is sort of one thing, but being able to sort of draw inferences based on that information is another thing. And then the final thing that they discuss is having sort of a set of values or a conception of the good. So you have to have an idea about sort of what you want, right? And what is going to be sort of good for you in order to direct your understanding and your reasoning and deliberation towards those goals. So again, nothing particularly unique to their conception of competence here, but something to sort of bear in mind. One thing that they do get into in this section, which is a little bit sort of difficult to sort of understand, is this this discussion about how competence, whether relative or fixed, is sort of to be understood as a threshold concept instead of a comparative concept. So they, one way to think about that is this sort of all or nothing kind of determination versus making a matter of degree determinations. So you're more or less competent in terms of a comparative thing. And they kind of go through that the reason that they're going to sort of look at this in sort of a threshold way, sort of an all or nothing way, in part, I guess, because that's the way the legal and healthcare settings work, which may be a bit controversial because, again, just because something is in a certain way doesn't mean that that's the way that it ought to be. So from a sort of a theoretical sort of standpoint, it's unclear whether this is the best way to set up our thinking of competence or not. But nevertheless, this is really all that's sort of being stated, is that this is the way that it is, and this is the way we're going to go forward. Okay, so here's the discussion of sort of the standard underlying sort of values when it comes to thinking about sort of competence, and why we are talking about this issue, and why it becomes kind of such a thorny issue, and that's because underlying this competence discussion are sort of two really important values. So one is the promotion of individual well-being. So to be competent, or having competence allows you to make sort of decisions about what sorts of things will enhance your well-being or won't enhance your well-being. So this is just a practical consideration here, that the more competent you are, the better you are going to be at sort of achieving your goals, and the more incompetent you are, the less able you're going to be to do that. And so a few things in this section that are sort of mentioned beyond just the obvious fact that medical treatments have the ability to enhance one's well-being, is that there's a wide variety of treatments that people are given, and even sort of non-treatment, and their beliefs about their treatment could have an effect on their well-being, and not just in this sort of means-end way, but it could be that well-being itself is determined by getting what you want. So there's a view on happiness and well-being called preference satisfaction or desire satisfaction, which essentially equates doing well with getting what you want, or at least getting what you want if you were informed. So that sort of plays into this issue of your competence or a patient's competence and individual well-being. But on top of that is the good old just respect for self-determination or autonomy. That autonomy, just making a decision regardless of whether or not it increases your well-being, is an important value. So again, this is sort of the Kantian sort of way to think about choosing and making choices, that the choice itself is important because it's about self-governing, it's about self-determination. And one point that they make in this section I just want to sort of mention is that in the legal terms, this is sometimes sort of cashed out in terms of respect for privacy, but it's more sort of straightforwardly from a moral point of view, an issue of just the good of self-determination or the good of autonomy. So anyway, these things are reasons to think about competence and to promote competence. But it's also the case that they conflict. So it's sometimes the case that self-determination, just sort of what the person wants, or even in an informed way, is not necessarily what's best for them. And so there are cases where respecting somebody's well-being, respecting someone's choice is detrimental for their well-being, and that's certainly what appears to be going on in the cases with Mary Northern and Dax, that both of these patients at the time were choosing things that seemed to be sort of at odds with their well-being, and there was this concern as to whether or not they were fully competent, right? So if they were fully competent, then we would want to respect their abilities to choose something that is anathema to their well-being. But if they weren't fully competent, then maybe that gives us a justification for overriding their decisions. All right. The third section is this deciding on a standard of competence. There's some discussion early on about sort of different standards that you might adopt. And one thing that they sort of discuss are these sort of two extremes that are probably just sort of obviously wrong. So on one end of the extreme is viewing somebody as competent just insofar as they meet the very minimal capacity to make a decision. So just expressing a preference could be understood as being competent, which would pretty much just leave out the permanently unconscious, right, or people in persistent vegetative states, right, that almost everybody else who's conscious has the ability to sort of express a preference. So that's a little too permissive for the authors, but so is the other end of the spectrum, too restrictive. So the idea that if we understand competence as the capacity to make the right decision, right, assuming that there's one and only one right decision, or maybe just a set of right decisions, then we've too narrowly defined what competence is. That competence should be at least possible when it comes to making the wrong decision, right? So even if there is a decision that is sort of incorrect, so one may nevertheless be understood as being competent to make that decision. So the gist of this is that the right answer is going to be sort of somewhere in between these two extremes. And of course, there's a lot of disagreement on the weights of the two values. There's the possibility that other values, such as the integrity of the doctor-patient relationship, need to also come into play when thinking about sort of an appropriate standard of competence. And then there's just a curious thing that they sort of mentioned here, which is they seem to be committed to this idea that there isn't really one objectively sort of correct standard. And I'm not sure if that means that they're moral skeptics or if it's just a confusion about the difference between the right answer and the difficulty in knowing the right answer. But nevertheless, they make this kind of throwaway statement in this section. So one thing that they do with in terms of kind of taking a stand on the appropriate standard is this relationship between the expected harms of a treatment and the benefits of the treatment and the level of competence. So they have this sort of table. The only table, I think, is on page 338, no, excuse me, 339. And what they say is that the higher the risk of choosing no treatment or alternative treatment, then the greater the competence sort of needed for making the decision. So to use a kind of a silly example, right, sort of say, you see that I'm about to sort of drink a glass of water, and so there's really sort of no risk to me drinking a glass of water. In fact, there may be some benefit to me drinking a glass of water. So you're really not going to bat an eye at whether or not I'm sort of competent in making that decision, right? There's the risk is sort of very minimal, and so the need for sort of determining competence isn't going to be sort of very high. But if you see that I'm about to sort of drink a glass of bleach, then you may want to know sort of a little bit more information that the risk to myself is so high that for you just sort of to just sit around and allow that happen would be sort of not the sort of right way to sort of go forward. Not that I shouldn't be allowed to do what I want to do, but it seems like this would be a time in which you would want to determine that, whether or not I really know what I'm doing, right? Do I really know that that's bleach? in the glass? Do I know what drinking bleach will do to me? So on and so forth. And so it becomes important, especially if you're in a sort of a caregiver situation, to make sure that the people sort of know what they're doing, that the risk is so high, um, that you need to know that I have sort of a high degree of competence, that I'm not sort of misinformed or tricked or something like that. Uh, and uh, uh, and then there's this sort of other discussion about the relation of a refusal of treatment to the determination of incompetence. One of the things that they mention is that there seems to be this asymmetry between sort of accepting a doctor's advice or a healthcare provider's advice and rejecting that advice. And one of the things that they say sort of in favor of that asymmetry is that it kind of makes sense that there would be an asymmetry if you accept that the advice is good advice, that the doctors know what they're talking about. So their discussion here is that, well, rejecting advice is typically sort of riskier. And then this goes back to that sort of table one, right? So if the doctor sort of advises you to do something and you go along with it, then well, then that's presumably going to have sort of a better net balance for your sort of overall health and well-being. But rejecting that advice is going to carry some risk. So in the first case, accepting the advice would not require as much of a determination of competence, whereas the second case would. Um, okay, so as I mentioned, the last section of this reading is sort of an argument that the author's conception of competence is better than the sort of traditional mixed minimum threshold conception of competence. And just to kind of reiterate what that conception is it's sort of very crude and general, which is that if somebody sort of meets a certain threshold requirement, then they're judged to be competent regardless of the sort of relativizing factors that the authors have been talking about, like risk or the amount of information required or their state at that particular time of making the decision. So it's just not fine-tuned enough to be able to make those kinds of distinctions. And so why then is this decision relative conception going to be so much better? Well, they kind of go through 5 reasons or points in favor of the decision relative conception over this fixed minimum threshold conception. So the first thing that they mention is that DR is sort of more in line with our informal determinations here. So it's more in keeping with a sort of a pre-theoretical view of how competence works. So that most people have a hunch that competence is relative, so a decision relative conception is going to be sort of better. DR also matches with the relativity of informed consent. So in other areas in healthcare where we kind of talk about these kinds of things, informed consent seems to relativize based on risk or the amount of information required and so on and so forth, that the riskier the procedure, the more information that we make sure the patients sort of know about before we can say that they've been informed. So DR can, varies with information just like informed consent does, but minimum threshold does not. DR benefits our legal framework. So with our treatment of minors, it is more or less sort of understood that minors' capacities to make decisions for themselves is relative, that they're competent in some areas and incompetent in others. So a relativized conception can make sense of that, whereas a minimum threshold conception can't. And also, with regards to our fit with our legal view of paternalism, DR seems to do sort of a better job, or at least that's what the authors seem to think. And again, paternalism is this idea that we can sort of choose for somebody, especially an adult, what's sort of in their best interest, regardless of what they want. So that's going to be tricky, that we typically don't like that, but that's what makes this determination of competence so important. The fourth issue is kind of a practical benefit that the view has, is that if you make the determination sort of relative, then it's sort of relative to that one decision. And if another decision sort of comes along, or another choice sort of comes along that's sort of different, or under different circumstances, the fact that they were competent or incompetent in sort of one decision isn't going to um, make them incompetent or competent in another decision. And again, so the more worrisome issue would be is that if they're judged incompetent once, then they're going to be sort of judged incompetent for all other decisions, regardless of risk or information. So again, DR can sort of make sense of that. Fixed minimum threshold cannot. And then finally, the authors sort of argue that having this sort of relativized conception brings about sort of a better balance between sort of competing values. Again, the competing values of self-determination and individual well-being. And if you make sort of an all or nothing decision about at the level of just these fixed minimum thresholds, then it's just going to be a much sort of cruder tool. It's going to be a much more difficult to make these sorts of distinctions that the authors have in mind. So their view, the decision relative conception, is sort of better suited to that task. So anyway, that's it. We'll talk more about this in class, and we should think about this with relation to the cases, the Mary Northern case and the Dax case, as to how to sort of think about their level of competence with the situations in which they find themselves. All right, so we'll talk to you later. Bye.